Welcome back to Weight and Metabolism. In this episode, we are going to be talking about oral Wegovy. Everybody was so excited for it. It's the new thing on the GLP-1 landscape, along with Foundayo. We're going to be talking about, I get asked about constantly in my practice right now, the oral form of Wegovy and how it fits into the broader landscape of GLP-1 medications that we have available right now. There's a lot to cover here, and some of the data is genuinely exciting, so let's get right into it. First, a little context. It's a GLP receptor agonist and has been around longer than most people realize. Exenatide, the brand name Byetta, was the first FDA-approved GLP back in 2005. So we actually have 20 years of post-marketing safety experience with this class of medication. The injectable Semaglutide, which most people know as Ozempic, was approved for type 2 diabetes back in 2017. And the higher dose version, Wegovy, was approved for obesity in June 2021. So Semaglutide has the broadest evidence base of any medication in this class, spanning the STEP trials, the SUSTAIN program, the PIONEER, the OASIS, SELECT, and SOUL, the widest range of FDA-approved indications, including obesity, type 2 diabetes, cardiovascular risk reduction, chronic kidney disease outcomes, and metabolic liver disease. Now, let's talk about efficacy data on oral Wegovy. What's new? So oral Semaglutide at 25 milligrams, and the data on it are really striking. The pivotal trial that showed that oral Semaglutide 25 milligrams achieved a mean weight loss of 13.6% at 68 weeks in adults with obesity who did not have diabetes. That's 11.4 percentage points better than placebo. Placebo is like if the patient was not taking anything. To put that in context, the injectable version of Wegovy, the 2.4 milligram subcutaneous dose, the highest dose, achieved about 12.4% points of corrected weight loss in the STEP 1 trial. And oral Semaglutide at 50 milligrams, studied in the OASIS 1 trial, showed 12.7% points versus a placebo. So the oral version is performing at near equivalent efficacy to the injectable, which is remarkable. Tirzepatide is still the leader in efficacy. I want to be honest with that if we have a head-to-head trial as well, the SURMOUNT-5 trial, and it confirmed that tirzepatide, which is the dual GIP and GLP receptor agonist, is still more effective for weight loss than semaglutide. In that trial, tirzepatide produced 20.2% mean weight loss versus 13.7% with semaglutide at 72 weeks, a difference about 6.5 percentage points. And nearly half of tirzepatide-treated patients, 48.4%, achieved 20% or more of body weight loss compared to 27.3% with semaglutide. The next trial that I'm going to talk about is the cardiovascular outcomes data on semaglutide. The cardiovascular data is truly where the semaglutide is truly unique. And I think sometimes it is underappreciated. We keep looking at the weight loss part of it. It is the only GLP-1 receptor agonist with proven cardiovascular outcome benefit across both its injectable and oral formulations, and patients with both with and without diabetes. The SELECT trial showed that injectable semaglutide 2.4 milligrams reduced major adverse cardiovascular events, MACE, by 20% in adults with overweight or obesity and established cardiovascular disease who did not have diabetes. That's a hazard ratio of 0.8. And critically, this benefit was consistent regardless of baseline blood sugar. The study will be linked below. Then in 2025, we got the SOUL trial results. The SOUL trial result studied the oral 14 milligram dose of semaglutide in adults with type 2 diabetes and established atherosclerotic cardiovascular disease or chronic kidney disease. And it showed a 14% reduction in major adverse cardiovascular events, hazard ratio of 0.86, which is statistically significant. So this is the largest driver, the reduction in non-fatal heart attacks. Now, neither tirzepatide or the oral Foundayo, the newest oral GLP, has completed cardiovascular outcomes trial. Here, semaglutide stands alone. Let's talk about Foundayo. I have done a full episode on that, and the difference from oral Wegovy is that it's a small molecule, and the reason why people are excited about it is that it's very practical. You can take it with food, no empty stomach requirement, no 30-minute fast, no restriction on water, can be taken any time of the day. Its bioavailability is also around 79% compared to less than 2% for oral semaglutide, which is why it has to be taken empty stomach in the morning. In the Achieve-3 trial published in Lancet in 2026, Foundayo was compared head-to-head to oral Wegovy at 52 weeks. At the 36 milligram dose, Foundayo produced 8.2% weight loss versus 5.3% with oral Wegovy 14 milligrams. And 76% of Foundayo patients hit an A1C target below 7 versus 64% with semaglutide. This is significant and also important. The comparison used the lower dose Rybelsus formulation, not the new 25 milligram oral Wegovy dose. So we don't yet have a true head-to-head between Foundayo and the higher dose of oral Wegovy. Also worth noting is that Foundayo had higher rates of GI side effects and greater increase in pulse rate compared to oral semaglutide in that trial. How do we think about this in clinical practice? So where does this leave us practically? Here's how I think about it for my patients. If someone wants the most proven cardiovascular benefit with excellent weight loss and is willing to do an injection once a week, injectable Wegovy. It remains the cornerstone option with the deepest evidence base. If someone wants absolute maximum weight loss with a dual mechanism, tirzepatide is still the efficacy leader. If someone wants an oral option and has already accepted that empty dosing requirement, oral Wegovy now delivers near injectable level efficacy, and it carries the cardiovascular safety track record as well. And if someone wants oral convenience with no food restrictions, no timing restrictions, Foundayo is a meaningful new option, especially as we get more long-term data on it. One more thing I want to say before we close. In 2025, a JAMA study looked at prescribing patterns for semaglutide and tirzepatide across the United States, and it found significant disparities in access by race, ethnicity, social vulnerability index, and whether patients lived in urban versus rural areas. This matters enormously to me as a physician and as an advocate. We have medications that work, we have evidence, and yet who gets them is still shaped by systemic inequity. That's something I think about in my practice every single day. And it's something we all need to keep pushing on as a field. Well, thank you so much for being here. And as always, the podcast is for educational purposes only and not a substitute for individualized medical care. Thank you.